team that is coming on. That's the headquarters, okay. So, if you're not speaking, you mute yourself. And then we have headquarters is going to be doing a recording of this session, as well as managing the chat. If you have anything to react, if you have anything to respond to during the session, you use the chat box. Use the chat box, and there will be people managing the chat. So they will help us pick all the questions that are coming through. But also those of us who are attending as a hub still use the chat box and help us know how many people are there. We want to know all the people who have been on the session. So please don't forget to enter in the chat box to know that this hub has got so many attendees, and then you write their names there. That will help us because we are now tracking the attendance. You know, when we had our meeting, our dinner in Amsterdam, they presented to us the analysis of the attendance, which was not good for most countries. So it is particularly good for us to register attendance whenever we have a session. So it's already time. I welcome all of us on the call. The rest of the people that will join us will find us on the way. I've already welcomed. Let me see if there's any a lighthouse. Lighthouse. This is this is Malawi. Is this Malawi? Lighthouse. Hello?
Yes, this is Malawi.
Okay, you're very welcome. Thank you for being online. Then I've already recognized Sierra Leone, Ibrahim, and team. Thank you for being online. Of course, Gesh, thank you for being online. Legacy, thank you. The headquarters, welcome. Thank you for being online. Nicholas, welcome. Thank you for being online. So now, today, as was indicated through our communications that we made earlier, is going to be pretty different from most of the sessions we have had. We are going to have 3 presentations, and the presentations are going to concentrate on evaluating our viral load cascade, our viral load implementation, using either the self-assessment tool. We have developed a tool. The core and oversight team of LabCoP has developed a tool that we have circulated to all of you. We sought to get your feedback ahead of time. It seems we did not get the feedback apart from the Malawi team, where all of us, I was there and we shared the tool. But the tool is easy, and I think you didn't have any trouble. That's why you never sent any feedback. But Gesh is going to be taking us through this tool, giving us highlights about the tool. Then we shall get presentation, one from Kenya and one from Tanzania, about the country visits, their impression and their action plans. So I take the pleasure to welcome Gesh to take us in the first presentation for about 10 minutes.
Thank you, Charles. I'm sure you can able to see my presentation, right?
Yes.
Yeah.
Good. So my presentation is just a quick one, just to give you a brief overview of the viral load test assessment tool. So I'll give you some introduction about the purpose, as well as the instruction to complete the tool. And I will also highlight the domains or the categories of the assessment tool. And finally, the next steps will be addressed or summarized by Charles, and hopefully we'll have some time for question and answer. So that's all about the outline of this presentation. So this tool is just to use it to have a rapid assessment of national laboratory system, supporting the HIV viral load test scale-up in countries participating in the LabCoP. So the purpose of the assessment is to assess the strengths and weakness of the laboratory system so that it is possible to monitor any improvements on the scale-up and the quality as well as the coverage of viral load testing. At the same time, it also determines the areas of support by the LabCoP as well as with other partners collaborating with ASLM or the country program. These are some of the consideration we need to keep in mind for completing the tool. The tool is not to replace the existing viral load assessment tool provided by partners and by the ministry. It is not to duplicate efforts. Rather, it is to complement the existing monitoring and evaluation system. Just like the other assessment tool, any other assessment tool, it helps us to develop a plan for better coordination to improve MND, coverage and quality of viral load tests. And at the same time, it helps us to share information about the status of the national viral load test scale-up. It's not for a particular laboratory, rather it is for the national laboratory. This will take us to the last point, which is really important to have reliable and accurate data for understanding the actual gaps. So we all need to have appropriate data source for getting reliable information. These are the main instruction to complete the tool. We need to carefully read and understand the question before we go to the responses so that we can able to get a good information. And all the questions are referring to the national lab. As I already said, it is not to get information from a particular laboratory or a group of laboratory. Rather, this information needs to reflect the national laboratory system as well as the actual viral load test scale-up in the country. The tool needs to be filled by the country team participating in the LabCoP, and the data source could be different. But as much as possible, we need to use different sources so that we can able to get reliable and accurate data. You may get the information from the National HIV/AIDS Prevention and Control Unit at the Ministry of Health, because most of the time they are the one who have got a comprehensive report. And we may also get from the National Reference Laboratory Center if they are the ones coordinating the national viral load test scale-up. And we may get also a report from the Ministry of Health and other partners or stakeholders in order to reinforce any information which is captured from all these sources. We may include the routine laboratory and clinical data and the reports, even key informants. The structure of the assessment really follows the viral load cascade that starts from demand creation, specimen collection, transportation, and the like. In terms of the questions, the list of questions, it starts with the general laboratory system that supports the viral load test, and followed by a detailed question on the viral load test. It is not exclusively the viral load test. Rather, it also includes the general laboratory system. The level of response to each question, it has 4 stages. But if you have any unique or important information, there is a blank space where you can able to complete, and you can also provide option. The tool provide option for additional information. The structure looks like this. It starts with general information, date of assessment, the country, person who's completing it, and the like. And as you can see from the table, the questions are organized this way. The list of questions are on the first column, and the level of response, it starts from number 1, or the orange color, to the deep green. And if you want to add unique or important information, you can write it on the last column. These are the domains or the main categories of the assessment tool. The first one is demand creation, and the second one is specimen collection and processing, and the third one is sample transportation and HIV viral load testing, result, utilization, leadership, and management. The demand creation part, just to give you some highlights on the main question, it targets the national strategy and procedure to increase demand for specialized or newly introduced laboratory tests. It's not only to the viral load test. As I already told you, it starts from the general laboratory system, and it goes to a specific or particular initiative to improve awareness of viral load tests. Under specimen collection, it addresses quality of sample collection. It asks whether there is a guideline, protocol, SOP, and the like, and it also asks about the compliance of sample collection and processing with regard to the national protocol. Sample transportation, it includes TAT, whether there is a national integrated sample referral network, for not only for viral load test, it includes TB, viral load, chemistry, hematology, and others. Under HIV viral load testing, as you know, this embraces a lot of things, but the questions are more of on the quality management system, whether the laboratories enrolled in the SLIPTA, and waste management, supply chain management, equipment maintenance, and the like. It addresses all these main topics. The last part, the national data on viral load and ART, as I tried to indicate in the beginning, you may get this report from the Ministry of Health or from the National Reference Laboratory, or any report by stakeholders, as well as with the Ministry of Health. The next step, I'll give the time to Charles to address this one. My presentation is all about the category as well as the structure of the assessment tool. Thank you.
Okay, thank you, Gesh, for that overview of the tool. Since you received this tool ahead of time, I know this overview just polishes up already the insight you have gathered through this tool. But keep your questions at the end of the session if you have any or any reactions. These are next steps regarding this tool. So basically, this tool is supposed to be filled by the country, by the in-country team. It is supposed to be submitted as one tool, and which means the country teams have to meet. The country team has to meet and agree finally on how to score. We want you to be as objective as possible as you score each of the indicators that are in that tool. This tool is basically to give us an overview of how our program is performing. It's not punitive. It's not to discourage or to fault find, but it is basically for us to make an objective assessment of our program, and then we start tracking progress through all the interventions that we are going to do. So the tool will help us identify the weak areas that need to be focused on, and that will set the pace of our next, where we are going to put our energies in the next phase of the project. So please fill this tool objectively. Then when you submit that tool online. You submit that tool to me online. And also you can submit it to LabCoP. You can submit it myself to LabCoP. And also you can submit it to Nicholas. You have our mails and we always communicate to you. Please submit the tool. And then eventually we gather all the tools from each country. Each country is supposed to have a finished tool. We give you the month of August as a month for you to do the country assessment. By the end of August, every country must have submitted in their tool. We are going to analyze the data during the month of September out of the tool that you have given us, and we will create a dashboard that we are going to share in our regional meeting, in our end of year meeting, which I'm going to tell you about, which we are going to have in the month of October. During the week of 15th of October, we are all going to congregate in Uganda, and all country teams are going to congregate here. And we are going to be showing you the performance, the status of our program, each country's program, using the dashboard that we will create out of the tool that you will have filled. So please take it very serious. We expect to get a filled up tool by the end of August. And then you give us time during the month of October to analyze the data, create a dashboard, which we are going to share during the regional meeting. So be as objective as possible, work together as a team. Don't submit more than one tool, submit one tool. The data may never be collected from one station. There's data that needs to be collected from the lab, from the program, from some key stakeholders like civil society and so on. But since all these different areas, these different sectors are represented on the team, make sure that all the different stakeholders make inputs into the team, the program people, the implementing partners, the civil society, the lab, and so on, so that we have a fair picture of what the country program looks like. So let us go to the next presentation by Tanzania. So Nicholas, flash the Tanzanian slides. I hope Tanzania is already ready. Do we have the Tanzania team on? Hello? Yeah. Yes, Mr. Kabuje. Okay.
Okay, can you slide show it? Okay, good.
Okay.
We are going to share some of the action items we had put on board to address the weakness following the assessment from our program manager from ASLM of our LabCoP program. So I'm Kabuje, VLO National Value Coordinator. So next slide. Next slide. Okay, thank you. So during the assessment, we had actually, the assessment was based on the entire cascades for viral load program. So we started from demand creation up to the results interpretation and client management. And the assessment was conducted on 14th to 18th of May by our lab program manager, Charles Kiyaga. So there was a number of observations and recommendations were made, and the detail we can also find in our report, which was circulated by our program manager. So we are going to concentrate more on the action item we had put on board. We started to implement on it. So next slide. Next slide. Next, okay, thank you. Action item starting with demand creation, which was the first cascades. We actually our objective is to increase viral demand creation beyond healthcare workers to networks of all people living with HIV. Earlier, it was found that we had been putting more effort on healthcare workers to create demand creation. So we had started to employ the following activities. So we'll continue strengthening viral load training and mentorship to healthcare workers. And also another activity which will be including is to sensitization to clients through morning talks, posters, the use of videos and audios elaborating viral load issues to clients in a waiting bay, especially in all ALT clinics. And we had already started doing some of this, especially morning talk. We had already started doing that, especially in our program in implementing partner. They are doing morning talk every on the Friday. And also we thought that we had already started doing sharing the list of eligible clients with clinician, home-based care providers, expert clients for close follow-up. So we expect this activity or technique will also help us to create more demand creation and reaching more patients. Also set appointment of eligible client according to the sample collection schedule. This is, we had already started doing this one, especially for big site, I mean large volume with clients. We had set appointment according to the day of what appointment to ALT. So we don't want to miss them, so we had scheduled them to come as according to our plan. Also, we advocate viral load daily sample collection from Monday to Friday in high volume facilities. So earlier, in some of the area, even if it was a high volume facility with high client number, we had not doing this viral load sample collection every day. So we had just doing at least 3 per week. So we thought that with demand creation or the operation which we are doing, we are now lagging behind according to our target. So we had insisted doing every day what sample collection in all CTC with high viral load clients. I mean ALT patient on care. Also, we started doing involving pharmacies unity to ensure that for all clients who had visited the ALT, I mean the clinic, before dispensing the drugs, he or she must also ask about if the client had been taken a sample for viral load. So we thought earlier people can be directed to go to the lab for collection of sample, and then a client might disappear without being taken a sample. So with use of this pharmacy unit, now we are now capturing all patients who are eligible to be taken for viral load to ensure that they are already taken a sample for viral load. And this had been already started to be implemented in HGF MLI, a DOD supported site in Southern Highland of our country. Also, the use of local radios for sensitization, for sensitizing the community. This had been already implemented, especially in DOD supported area. They are using local radio, broadcasting radios in the area, in the Katavi region. And for the program, it is doing this use of advertisements through our Tanzania Broadcasting Corporation. So this had been already in implementation. Next slide. Next slide. Thank you. With another cascade, which was sample collection and transport, our objective here is to capacitate the hub to start reaching spokes for sample collection rather than spokes reaching out to the hubs. So one of the position was we had area practicing, it was hub which was, it was spokes which was reaching the hub. So it was, we sought to employing this practice, good practice from Uganda of using hubs to reach spokes will be also effective and cost effective. So we had talked to one of our implementing partner who is Management for Disease and Development for Health, MDH. So we started to pilot the hub spoke pilot by reaching through hubs. So we had started doing this in one of the region called Kagera. The region is supported by MDH, who is one of the members in our LabCoP program. So we had already doing this, and we expect to visit the site, and we'll be giving feedback to the technical working group. Also, another objective was to establish integrated sample referral system. So we had already started, we didn't want to start with all program. So we decided to start with TB program, in which we are actually using the same equipment for near care of point. We are using Gene Expert platform to test viral load. So we had decided to start with this program to integrate a sample referral system using the same means we have with TB samples. So the rollout plan between NACP and TB program had been already done. So we have already document for rollout plan for Gene Expert in use of testing for TB and viral load in near care services. And for integrated VLO and TB, we are still we are not yet taken in board, but we are doing that. We are on a talk to make sure how we can start with this. And for the viral load capacity optimization, our objective is to optimize VLO testing capacity. So with this, we are really looking on a consultant to work with our team to finalize web-based dashboard for easy lab coordination and program monitoring. So in our country, we had already started working on preparing web-based dashboard for easy program monitoring of VLO progress, but we are not yet to the final dashboard. So we are looking for consultants to work with our country team. Also, to hire more human resources, we had agreed that, and CDC had approved in some of the implementing partner to add some more staff to work with the VLO laboratory, especially in the area which are having high, which are serving more regions, like in Lake Zone. CDC had approved to hire more 10 staff per one testing lab, which is Bugando Zonal Lab, and it do serve more than 7 regions, and it is area where there is somehow high prevalence of viral load. Also, to start working more than one shift in lab. So earlier, some of the labs had been testing only normal working hours, I mean 8 hours shift. So now we had advocated to do more shift, I mean at least 2 prolonged working hours. So we do pay some of the extra allowance for extra works. And also to make close follow-up to ensure minimum equipment downtime. So we had talked with our vendor and we agreed that the vendor should station their engineer to at least zone-wise. So it is Roche company, I mean sites, as their business partner in the country, had already allocated some of the at least 1 engineer to service the equipment per zone. But currently for other vendor, they are not yet done that one, but they are approaching to do that. Next slide. Okay.
Let us be a bit fast.
Okay, yes.
The last one.
For that utilization, we had put some of the activities which we, I mean action item, which we hope will help us to really utilize and the result and make good follow-up for patients. One was interfacing between laboratory central database into CTC2 database. So we had already started doing that one to interface the testing lab, I mean that central database with CTC2 database. So we hope once we finish this one, once we test in the lab and authorize the result, will be going direct to the patient file automatically. Also to scale up our LAC project-based practice for flagging high viral load results and use of phone call to patient for calling up the patient to come to the ALT area as possible to start enhance their adherence counseling. We had now planned to scale up, and we had already shared the progress with the IPs to scale up together with a local government lab practitioners and healthcare providers for ART. Use of high value load result register. So we had also employed this, we had developed the register to register all patients who are viral and suppressed for easy follow-up. So we are using viral load champions to make follow-up on those registered patients with high viral load through phone call and visiting their sites for follow-up so that they can come back to the clinic for intervention. Also for the point of care, we had agreed that integration between both centralized and point of care planning into one team. So we had accepted that we are now going to discuss everything about point of care in technical working group, and any agreement will be coming from technical working group instead of area program, which was running like independent program, where it was one. Also point of care more to be promoted for EID testing, because we are sure that EID testing is a more diagnostic test. So we hope for viral load with our current capacity, we can continue using our conventional platform instead of hot EID. And these are some of the best practice as observed in LAC project. You can see in the left-handed, there is flagging, signifying that the patient has high viral load.
I think that is good enough, Bwana Kabuje. I think you have really expounded so much on what the country is planning to do. Thank you very, very much. Let us the Kenyan slides. Tanzania, thank you very much.
Thank you, Charles.
Yeah. Can we have the Kenyan slides on? Hope the Kenyan team is ready. Get on stage. Nicholas, are you having a problem? Should we assist? Nicholas? Okay, so if the Kenyan team is ready, let me share the slides here.
I'm sharing the slides. Are you seeing them?
Yes, we are seeing the slide. Okay. So Nancy, are you in there? Hello? We have the Kenyan team on. Hello?
Hello, dear child. This is Pascal. I think that while we are waiting, maybe we can give the opportunity to the participants to ask questions.
Okay, for people to react. So the Kenyan team is not ready?
I'm ready, but I can't see the presentation.
Okay. So can we go?
I can't see the presentation on your side.
The presentation is not there.
Okay, yeah.
From your side.
The rest of the team seeing the presentation?
The presentation is there
Nancy,
now.
are you seeing the presentation?
Unless I open myself, I can't see.
Zambia, we can't see the presentation.
Oh, you can't see the presentation?
You cannot see.
No.
Then there's some problem then.
Yeah.
Okay, while we are solving the problem, can we give the floor for a couple of questions?
Yes. So can we?
Nicholas.
We've been having people monitoring the chats, the chat box. They can bring out some of the key questions that are coming out, but you can also, by a show of hand, indicate when you have something if you haven't yet put it in the chat box. Meanwhile, Nicholas, I think you are trying to fix up the issue of the slides.
So okay. I think there was a question from Dr. Bruce who asked, I think Dr. Gesh, whether the assessment tool should be filled in by a committee at the same time, or whether several people can fill in the tool one after the other. So that's a question for Gesh.
I can see my presentation has come.
Okay.
Yeah, we'll give the room for Gesh to answer and then we'll start with yours.
Pascal, I think that's a very good question because the team need to coordinate among themselves and come up with one as a completed assessment tool. So they need to have a focal person from the participating countries, and so that they can also even collaborate with partners to get adequate information and reliable information. As we already explained during the presentation, They can get the information from the ministry report, from partners. So it is better to get support from the partners if they can able to get the technical assistance and the support. So it is better to coordinate among themselves and come up with one completed assessment tool.
Thank you, Gesh.
Okay, thank you very much, Gesh. So put the slide on slideshow and then let Kenya go through quickly through your slides in 10 minutes.
Okay, thank you. Good afternoon.
Good afternoon.
Good afternoon.
I can go through the slides on the next slide, please. I think first of most is to just appreciate Charles and Lekese for coming to our country and just seeing it's like assessing us in terms of our best practices and what they see is our challenges. So today is what I'm sharing in their recommendation on what they think we need to improve. And I think since the first slide is the same with Tanzania, is whatever we are covering is on the line of the viral load cascade in terms of recommendation from Charles and Lekese. So next slide. Next slide, please. Yeah, so in terms of demand creation, their recommendation was that there was capacity needs to be put to the patients, capacity build patients in terms of to do their demand creation for viral load. And I think what I'm presenting is a discussion between the viral load technical working group who are actively working on this. And according to them, again, they had said this is being done. It's only that the country, we do it through media and at the facilities on a weekly basis, and it's done by community health workers. Only our challenges is that the people do on voluntary basis, and maybe it might not well because of funding, which supports these people on voluntary basis. And our plan is to engage more the implementing partners to support us in that they can be able to motivate more or give the incentive to these voluntary community health workers. And that is our plan as the technical working group. The same for the sensitization of sensitize and educate the people living with HIV, to empower the membership to request the viral load and results utilization. We've just said again, the same things happens, but the challenge we have is the funding the same time for the implementing partners. And we will reach out to the implementing partners more so that we can work as a team on how we can utilize them. In terms of integration of uniformity of no integration, they noted that we don't have an integrated transports coordinated in the central lab. We have one at the moment currently, but it's only for viral load and EID. And I think their recommendation was if you can use the viral load EID to accommodate other tests in terms of viral load to support TB, hematology, and other samples which are referred to the central lab, we can utilize that. And I mentioned that we borrowed heavily. We have a document which came from Uganda, and the NHRL is trying to develop that viral load specimen referral implementation framework to support that, and we will borrow heavily again from the Ugandan framework thing. So Kenya is a decentralized specimen referral system with partner support. Focus. Again, what affects us is because the country is dynamic. It has different dynamics. This sample referral, there are people which is hard to reach that the courier could not reach there. So partner supports in terms of sample referral using their own vehicles to transport samples to a site where these samples can utilize the courier service. I've just mixed the things. I didn't go, and again, in terms of mapping, we've said we will review the mapping in our last quarter of the year, because that is when we have a support in terms of funding in the last quarter. So we review that so that it can support us. In terms of national curious coordination, I think Getachew saw that we are partners. We depend mostly on partners, but for sure, viral load and EID is fully 100% PEFA, and we have one partners supporting the level of curious service. And I've said that it's only because it's only for viral load and EID, and we will only. We are planning as a technical working group to develop a M&E framework we are planning to develop one so that it can enhance uniformity of various implementing partners, so that we can make them uniformity and discuss these implementing partners can do what and the other one can do what. In terms of lab capacity, there is need to additionally, from their recommendation that to them they saw there is no need for additional labs or equipment into the country. But the technical working group again sat again and look at that. For us, there is need of additional labs because our labs we utilize now are research labs, and because they are the ones which had capacity by then, but capacity is moving towards our MOH facility. So opening of new labs means we will close the others. It will still be standardized that it might be different labs, but utilizing the same in the country. And for sustainability purposes, there is need to transition, as I've said, need to transition from this research institution to MOH facility. And again, we'll be able only to replace aging equipments, which have, because I think since then we have some equipments which have gone beyond 6 years, and that is the only equipments we might change. And again, in country, the policy says we don't want to go directly to one company or one manufacturer. So they are open to having different equipment utilization. In terms of country to consider 24-hour shifts to optimize output, I'd say again the country prefers the use of 8-hour shift. We have different laboratory happening in different counties or high burden counties, and at the moment we are meeting the target within those 8-hour shifts. It's only the utilization to optimize the equipment, which was said the 24 hours can work well, but we will review that again. Next. Kindly next slide, please. So in result utilization, different option of accessing results electronically is real time. Their recommendation was that the non-suppressed results should be flagged, or results communication to the patients should be mainstream rather than vertical. Scale up of viral load champions at facility level, and follow-up of non-suppressed patients to be optimized. So we agreed again and say these recommendations are already being implemented at the lab clinical interface. We are utilizing, or we have incorporated the clinical team to join the lab team in their viral load technical working group, and that is the clinical interface. The lab clinical interface are the ones who are discussing these particular issues which have come up. And again, we are factored in the viral load champions that in our next quarter they can scale up the addition of other use of viral load champions in facility. In the use of POC, adoption and rollout should be centralized, coordinated at the program's MOH facility. We say there is an active viral load EID that is in charge of coordinating POC program, and POC program is under the EID viral load technical working group. So they don't work in terms of, we say we continue to engage POC and viral load technical working group, which is ongoing, to ensure that the viral load and EID testing has been harmonized, to ensure that POC complements and meets viral load EID testing needs. So the POC will just be introduced to unmet needs, and we've started using it just through pilot in terms of EID that meet needs.
Okay.
Yeah.
Okay, thank you very much. Thank you very much, Kenya and Tanzania, and Dr. Gesh, for the very elaborate and very insightful presentations you've made. We have about 11 minutes left for us to react to the questions that have come through and those that are yet to come. So we had a presentation on the tool. Then the two countries, Kenya and Tanzania, were sharing their experience after country visits and highlighting what they plan to do in light of what the assessors observed. We have seen a very elaborate plan from each of these countries on what they are going to do. So can we react?
Can I ask from Zambia?
Okay.
Yeah, the tool that was shared, was it the one that was used to assess Kenya and Tanzania?
A good question. No, Kenya and Tanzania, we had not yet finalized the tool. We went in and worked with them through the process, their viral load processes, and picking information from the stakeholders. We are able to make observations and came up with recommendations using the extensive experience and the country interaction that we had. The tool is rather more systematic, more spot on, relatively summarized, and we'll be able to pick on a few things. So it is a tool that countries can use to do their own country assessment.
Okay, thank you, Charles.
Yeah.
Yeah, thank you, Charles. This goes to Nancy from Kenya. Can we go to the first slide about capacity building?
No, I think you just asked the question because we have already moved away from the slides.
Okay, when you look at Nancy's presentation, there are a gap in the capacity building, more so for the health workers. But when it comes to what they are supposed to do, they are looking at patients. I'm wondering, when you did the assessment, did the health workers have the capacity to use viral services to manage patients? Because according to what they are supposed to do, they are looking at patients only. But what about the knowledge and skills for the health workers? What are they going to do? Maybe we can share an experience of the Ugandan team, where our capacity building, first of all, we developed a curriculum, which we used to train the health workers. And then we held national TOTs to have a pool of national trainers who would actually go and carry out regional trainings. So once the regional trainings are done, we have a pool of regional trainers who now go and do facility-based trainings, so that we reach as many health workers as possible.
Yeah, I think from the assessment we did, they do that pretty well. Where the gap was on the side of the community. And that's where a lot needed to be done, not only in Kenya, but in most countries. So that's why it was highlighted. But those which were not highlighted were pretty strong. Other questions?
Yeah, hi, Charles. This is Clement from CDC Atlanta.
Okay.
Just a quick comment on that response. I think we were looking at the lab committee of practice. We are a bit reaching out into the clinical care and community, which the mandate of the lab may not have that mandate to be able to go out there to reach out to the community. I'm not sure if we're going to the right community of practice, because like what Nancy presented, Nancy's mandate is limited to the lab. Reaching out to the community belongs now to another group of clinical practitioners, and I wonder whether are we asking the right question to the right community of practice. And so demand creation, it may be a bit tricky for the lab to address that when it belongs to the clinical practice. Then That's just one comment I just want to put out there, and then we can discuss it. I have other questions. I don't know if I can go into that, or I know there are plenty of questions that other people have.
Okay. I'm bringing up the other question.
All right, let me just quickly ask the other questions. Back to Kenya, the issue about talking about double shift, triple shift, or whatever, working 24 hours. Again, let's bear in mind that each of these countries have different labor laws. I was in Kenya myself, where we tried to implement double shift. It wasn't possible because of the labor laws in Kenya. It does not allow that. So again, community of practice should take into account what are the local laws in those respective countries. So Kenya might not be a country where you can implement more than one shift. And that's the reason why we did, PEPFAR and the ministry have worked together to do this instrument mapping for almost all the PEPFAR countries to be able to work within that 8 hours, increase instruments where we need to increase, and then be able to work on it. But the one point you keep talking about, point of care, which I want to just talk about it. Like Tanzania, the use of point of care, is this a ministry-head policy on is it community of lab practice? Is using what is in existence, or is it trying to bring something that is not yet even in existence? The point of care in Tanzania is still being evaluated, not really as a program yet. So I'm wondering, from this community of practice example that's been given for point of care, is it truly what is being implemented? Mostly a viral load. I think Tanzania can try to clarify that.
Okay, maybe let me respond to the one of the community. Is this appropriate question for the laboratory community? Actually, this community of practice is not only laboratory, much as it is laboratory strengthening community of practice. But when we look at the viral load cascade, it brings on board all the other stakeholders. So when you look at the in-country team, you will find there are clinicians there, there are civil society, they are implementing partners, even funders. So it is all embracing. So as we are talking about this, we are not necessarily saying the lab should do it, but we are saying the whole community for the viral load cascade should be able to advance demand creation. So is there somebody who wants to respond to? We had another concern about the equipment. I mean, the laws, the local laws. Yes, we agreed with Kenya that increasing the equipment and the human resource hands would alleviate the need for night shift, which is okay. So do we have is there anybody who wants to react to what Dr. Kelmet has said?
Well, I have a question. This is Pascal here, and I want to follow up on what Dr. Zay is saying about the point of care. So it's a general comment about the action plan, and because the action plan looked like a list of things and component of the viral load cascade, but it's not very clear to me how Kenya and Tanzania have actually prioritized the component that have the most likelihood to have an impact, and also the component that are not yet addressed by the partners on the ground. So that's very difficult to see what actions are they going to start with, and how are they going to do that. Like the point of care, like Dr. Klema is saying, might not be so relevant now for Kenya. So you wonder, why is it on the list of the activities of the action plan?
Yeah. Hello, Daniel. I think you need to mute yourself. Daniel, you may need to mute yourself. Yeah, actually, why POC comes into the discussion is that we found in these countries there were POC initiatives that were not necessarily very well integrated with the centralized testing. And it was observed and it was highlighted that if there's going to be any POC effort, it should be integrated into the central viral load program so that we don't have two different interventions for viral load, one for POC and one for centralization. That was a glaring thing that we could see in countries where we went. That's why the countries came out to say what plan they have to try to integrate so that it is one program. But otherwise, we are going. Okay.
Charles, this is George from OGAC in Washington, the PEPFAR office.
Welcome.
Yeah, thank you. I just want to chip in a little bit on this point of care for viral load and EID. And of course, we are all working together within the Integrated Diagnostic Consortium, where ASLM is an active member. We all know that at this point, for all our programs, we are conducting pilots, which I know about the Tanzania pilots being supported by China and other countries for viral load POC. And I think that is a message that we should be sharing with everyone to know that these are still pilots. We're still trying to determine the actual place of POC for viral load, support viral load. And of course, we are supporting POC for EID, and that has been our global discussion. So let us try to make a distinction here because we've had it all the time, and some countries feel that it's all scale up for POC for viral load, just like what we have for EID. So I think let countries understand that it has an opportunity, it has a place, but let us make sure that the pilots are completed, and then we can have more data to share to really determine the appropriate use of this tool to support viral load scale up. I'm sure our meeting in September that here in Washington with Unity, ICAP, WHO, and Global Fund, we'll be sharing some of the preliminary data. So I just want to make this clear so countries don't get confused. And again, it's clear that once something is not yet fully known and fully scale up, then you can't talk about developing a policy to scale it when you don't yet know what it actually means in terms of the big picture of the country. Thank you.
Welcome. Thank you for that.
Yeah. Charlie, someone has a question about the tool in the chat text that probably we will try to answer. And the question is from Nora from Zimbabwe, and she says the tool is fairly simple, but should be easy to follow. The only challenge that I foresee is trying to categorize the degree of implementation for the various activities into the predetermined color-coded categories. Sometimes it won't be as straightforward and quite distinct. So I think maybe you could try to address that, Ogesh.
Actually, it is a comment. I agree with the comment. It's good that they said it is simple and straightforward to complete it. It's right that if you don't use different sources to complete the tool, it may be even hard to categorize the degree of implementation. As far as you try to get different sources, fairly you can identify the stage of the implementation. Of course, it may be a little bit challenging, so I recommend to use different sources and the right and the appropriate source to complete the tool.
Okay, thank you very much. We are running out of time. And also you have to have consensus. As we said, it is better to fill the tool as a team, as the country team, not one person. So you all agree and have a consensus to say this is the best color grid for this particular indicator, so that you objectively assess your program. You don't need to underestimate or overestimate. You just have to be objective, because that's the way it will help us moving forward. Thank you very much for this very interesting and exciting and insightful discussion that we have had. We have so I would want Daniel, I think you need to mute yourself. You need to mute yourself. Yeah. So I want us to close the discussion at this point. I want to make a few announcements for those of us who are not there at the start of the discussion. We are planning this tool is going to have to be filled during the month of August. We are giving countries the month of August. By the end of August, all of us must submit in a filled-in tool, objectively filled, for us to be able to put it, to do an analysis of the data submitted and also create a dashboard that we are going to share during our October meeting that we are going to have. We are going to have a meeting during the week of the 15th of October for all the LabCoP countries, all the country teams. All of us are going to congregate in Uganda, and we are going to have a couple of days walking through what has happened through the year and planning for the next year. So we look forward to that, and please use the month of August to make sure that you fill the tool and submit it. Submit it through my mail, submit it through Legacy's mail, so that when you submit it to me and you copy Legacy or Dr. Pasco or Nicholas, it is fine. But make sure your tool gets to us before the 31st of August for each country. One tool we need filled for each country. And next month we are going to have a discussion on POC. There's a lot of confusion out there, but we want to make it very clear on how countries like what the Washington colleague has said. We need to give guidance. We need to have countries know what should be done at this point in time with the POC and also the plan moving forward. So we shall have a very interesting discussion from the POC folks. Please just keep the ears on the wall. On the wall, we will be informing you on what is coming in. Otherwise, thank you very much. Those of us who were in Netherlands, who attended the dinner, thank you very much. Those of you who missed, we attended on your behalf and we ate on your behalf. Thank you very much. Have a nice and a great month.
Thank you. Bye.
Bye-bye.
Bye-bye.